I'm Raj Makkar from Cedars-Sinai Medical Center in Los Angeles. So we are going to be presenting the results of the STS ACC TVT Registry with the tricuspid valve replacement using the EVOQUE valve, since that's the only device that's available. And this is data on more than 1,000 patients in the TVT registry. I will be doing live cases precisely at the same time. As my colleague Dr. Rahul Sharma will be presenting these results on the behalf of the group. Our goal here was to study transcatheter tricuspid valve replacement in the real world. So the EVOQUE valve was approved last year, and our goal was to take all of these patients, because in the United States, all patients who are treated with transcatheter technologies are enrolled in a national registry called the STS ACC TVT Registry. So essentially, what we did was we took patients from March of 2024 to March of 2025, and we took these patients, and these were more than 1,000 patients. In fact, 1,034 patients who underwent tricuspid valve replacement using the EVOQUE valve. So our purpose was to see what the clinical outcomes were in these patients, what were the echocardiographic outcomes, and what were the quality of life outcomes in the real world. I think we can say that the EVOQUE valve is basically a percutaneous procedure done from the femoral vein, and it requires no surgical cut down. This valve is essentially available in 4 different sizes that allows the operators to cover most of the patients, with dilated or enlarged annuli that is often seen in patients with tricuspid regurgitation. So I think, we'll have to wait and see what the 1-year outcomes are. And I'm hoping that they will be as good and encouraging at 1 year as we saw in the TRISCENT trial. So the patients that were enrolled are where the EVOQUE valve was performed in the real world were old. The average age was 77 years old. About 85% of these patients had atrial flutter or fibrillation. Most of these patients were quite symptomatic. Almost 3 out of 4 patients were in NYHA class 3 or 4. Also, as is the case, almost 1/3 of these patients had prior pacemakers or leads across the tricuspid valve. So that was also an important thing for us to study. The etiology of tricuspid regurgitation was mixed, roughly 40% primary, 40% secondary, and other cases were mixed, or some cases were also about 10% were related to or attributed to the pacemaker being the cause of tricuspid regurgitation. And what we found was that the procedural aspects were actually good, in the sense that the procedure time was about 100 minutes in these patients. Most of these patients were done with general anesthesia, and the valve was implanted through the transfemoral approach. In terms of need to convert to open heart surgery, it was less than 1%, in fact, about 0.8%. Also, what was important is that most of these patients actually went home. So they were discharged home, almost 94% of the patients. And the other 2.5% were discharged either to nursing care facility or to extended care rehab programs. The in-hospital mortality was 2.3%. At 30 days, the mortality was 3.1%. I think it's also important to point out is that compared to the TRISCENT trial, which was the randomized trial published in the New England Journal of Medicine, these mortality rates actually compared favorably. In fact, they were a little bit lower in this real-world setting, where the procedures were done in almost 80 sites. So one of our big concerns was This is a very image intensive procedure. Are we going to be able to replicate the results of what we saw in the TRISCEND trial in the real world, at 80 sites amongst lots of new sites? And I think surprisingly, the answer is actually yes, because as I mentioned, the mortality was, if anything, slightly lower at 30 days, 3.1%. But most importantly, the bleeding rates actually came down significantly. All bleeding rates were 7.9, but major bleeding rate was only 1.3%. One of the things, and this may be somewhat related to the definition of the major bleeding between the TVT registry and TVT, but nonetheless, despite that, the bleeding rates are down. And I think this may reflect that we have actually overcome some of our learning issues in how we handle the catheter and also how we actually treat our patients. And some of the other complications, such as valve embolization, were also actually quite low. In fact, valve embolization rates were 0.1%. Valve migration rates were 0.6%. So I think if you combine migration and embolization, these rates were actually well below 1%. So I think that's also encouraging. And as I mentioned, that 1/3 of these patients actually had pacemakers in place. So despite that, we were able to do this procedure safely in those patients. So what we did was we compared these patients, with pacemaker, without pacemaker, and the outcomes were actually very similar, both in terms of safety and efficacy. One of the key findings is that the purpose of this device, of the EVOQUE valve, was to reduce tricuspid regurgitation. And in the real world, the EVOQUE valve was effective in reducing tricuspid regurgitation, making it either mild or less in almost 98% of patients. So these results compare very favorably compared to tricuspid valve repair with the TEER procedure, where those numbers are around 60% or 60 to 70%. So I think in the real world, this was very, very effective in terms of reducing tricuspid regurgitation. Also, one of the key metrics is, what did it do to the quality of life? So the average increase, the mean increase in KCCQ scores was 22 points, which is very significant, all right, as an average. And then when you break it down, you can see that almost 2/3 of the patients had very significant increase, which is, more than 20 points. More than 50% of patients had at least moderate increase in KCCQ scores, which is, more than 10 points. So I think these results, so not only in the real world did we show that we can replicate the safety of the randomized clinical trial, that we reduce the bleeding rates. And very importantly, one of the other things that I forgot to mention is actually the pacemaker rates. In the TRISCEND trial, the pacemaker rates, the new pacemaker rates were almost 25%. In the TVT registry, at 30 days, about 15% of patients needed new pacemaker rates. So I think we are seeing progress. And we see what we saw in the TRISCEND 2 study. In terms of safety, we are better. In terms of effectiveness, we are as good in the real world, with 80 different sites compared to 30 experienced sites in the TRISCEND trial. We also showed that we were able to move patients from NYHA class 3-4 to NYHA class 1-2. In fact, 80% of patients after tricuspid valve replacement were NYHA class 1 or 2 at 30 days, compared to only about 25% at baseline. We've demonstrated improvement in quality of life using KCCQ scores. So I think all in all, yes, we are missing 1-year data for now. These are 30-day outcomes. And of course, all real-life registries have some limitation. The data are not core lab adjudicated, and there may be certain degrees of unreporting, but nonetheless, I have to say that we are very encouraged by what we have seen in the real world with the use of tricuspid valve replacement. I think these results indicate that the therapy is scalable in the real world, and it is actually here to stay for our patients.